Okay. Today we're lucky enough to have Prothena with us. We have Gene Kinney, CEO, and Tran Nguyen, CFO. My name's Greg Harrison. I'm an associate on Jeff Meacham's team, and with me is Scott Puckhaber. So I guess we'll just get right into it. Maybe start off with the prasinezumab program in Parkinson's. So you recently published the phase 1b data. Just curious, we saw, a good PK/PD profile. What beyond that did you guys find especially meaningful as you progress this program?
Yeah, no. Well, first, Greg and Scott, thank you for having us. We very much appreciate being here. Just to speak a little bit about prasinezumab, maybe I can kind of introduce a little bit of the science behind it, and then we can talk about this phase 1b results. So that's a monoclonal antibody, previously known as PRX002. Targets a protein called alpha-synuclein. Alpha-synuclein is a protein that I think amongst the field many people see as really the smoking gun with respect to cause and progression of Parkinson's disease. So we're excited to have a way to intervene in that biology. And as you indicate, we've taken that through a phase 1b study and are now currently conducting a phase 2 study, which is a proof of concept / proof of biology study with our partners at Roche. And we have a very good partnership with that team, moving that molecule forward. So in the phase 1b study, we were able to test multiple doses of prasinezumab. It was 3 monthly doses at various dose levels in patients with mild to moderate Parkinson's disease. Approximately half of those patients, plus or minus, were also taking concomitant symptomatic treatment, so it was a bit confounded from a symptom perspective in terms of being able to measure that. But what we were happy to see was that at dose levels all the way up to and including 60 milligrams per kilogram IV and 3 monthly doses of that, we saw relatively well-tolerated, safe, and meaningful dose levels. The only real thing that we found in terms of a safety signal was some infusion-related responses, which is not uncommon for monoclonal antibodies at those types of concentrations. And in fact, that dose level is a dose level that we're approximating in the phase 2 study using a flat dosing regimen in the phase 2 study. In the study, not only was the drug relatively safe and well tolerated, we also showed by looking at some pharmacodynamic measurements that we could, for the most part, saturate free alpha-synuclein in the circulation of patients at the dose levels tested. And of course, that was quite important because it puts the safety into context. At dose levels that were having a maximum impact on free levels of peripheral synuclein, we were still maintaining a relatively well-tolerated overall profile of the molecule, which is important. And what that allows us to do then is to actually take dose levels into phase 2 that we think can optimally test the hypothesis. And of course, the hypothesis clinically that's being evaluated in this phase 2 study is that interfering or lowering that alpha-synuclein, particularly in the central nervous system, will lead to improvement on various endpoints related to Parkinson's disease. A little bit of, a little different in the phase 2 study. Some of the things we're doing there that are different than the phase 1b, we are asking patients to stay off the symptomatic treatments, in particular dopamine replacement therapy. So these are your dopamine agonists, your L-DOPA types of treatments for the first 52 weeks of the phase 2 study. And the reason for that is we really just need enough time to evidence the progression of Parkinson's disease in those patients, which you would not have had in the phase 1b study, given that it was only a 3-month study. And obviously, we want to be able to look at endpoints that would measure benefit that would otherwise be confounded by the use of those treatments like L-DOPA and other things. So we felt like it was a very important study in terms of the phase 1b study. It was a very important study with respect to allowing us to select the right doses to move forward, making sure we understood how much of the antibody actually crossed into the central nervous system. We found across all doses about 0.3% of circulating levels got into the central nervous system. And in understanding that, we could take dose levels forward that we felt, at least based on our preclinical modeling, would allow us to saturate the synuclein in the brains of those patients as we move forward and optimally test that hypothesis. So that's, I think, what it did. It was a very permissive study in that regard. We didn't expect to see disease progression in 3 months. The disease progresses much more slowly than that, nor did we expect that we'd see anything really on clinical outcome measures in as much as many of those patients were using symptomatic treatments. And of course, we didn't observe that in those studies either. So.
Okay, great. You touched on the theory of alpha-synuclein as a cause of Parkinson's. Maybe you could just talk a little bit about that and, what gives you confidence that that's the right approach versus other ways of trying to treat the disease?
Yeah, I think there's several lines of scientific evidence now that strongly implicate alpha-synuclein in, again, the cause and progression of Parkinson's disease. I think the genetics are an important component of that. If you look at various hereditary forms of Parkinson's disease, particularly those that have a hereditary or familial change in the synuclein gene that encodes for the protein alpha-synuclein, you can see that they lead to, in many cases, early onset Parkinson's disease. You can also see duplication or triplication of the gene that encodes for alpha-synuclein. That also leads to an early onset disease typically, and sometimes with a very aggressive course. What seems to be common amongst these different hereditary changes are that they lead to a more pro-aggregatory form of alpha-synuclein. So it does point us in terms of the biology to this idea that aggregation of synuclein seems to be the problematic part of the disease process from a pathogenic perspective. And of course, one of the things that we've done with prasinezumab is selected properties in that antibody that strongly prefer the more aggregated forms of alpha-synuclein over the less aggregated forms of alpha-synuclein. We think that's actually an important component of prasinezumab. I would say that in addition to the genetics, you also have, on idiopathic cases when these patients come to autopsy, you typically see very typical alpha-synuclein inclusions in the brains of these patients, known as Lewy bodies and Lewy neurites. It's almost definitional with respect to the postmortem diagnosis of Parkinson's disease as well as related alpha-synucleinopathies. So we think that there's strong evidence there. In fact, I think many years ago now, we thought of Parkinson's probably a bit erroneously in just the stark terms of movement dysfunction. And I think what most of the field is moving towards now is that Parkinson's disease may in fact be almost a whole body synucleinopathy. You tend to see symptoms and signs of Parkinson's disease that sometimes precede the motor dysfunction, sometimes come after the motor dysfunction, which can occur in the periphery as well as in the central nervous system. So constipation is one that people talk about quite a bit. There are changes in skin innervation that seem to occur. In the brain, even what we're now talking about in terms of some of the prodromal symptoms of the motor dysfunction in Parkinson's disease. We talk about sleep disturbances, REM behavior disorder. We can talk about loss of sense of smell, hyposmia. And what's interesting about that is you actually can see in the neuropathological series that have been published, the postmortem neuropathological series that are published, the pathology, alpha-synuclein deposition, seems to underlie a lot of those symptoms. So as you see that pathology spread from brain area to brain area, you can see those symptoms come into play, at least on a temporal fashion. It's not perfect in terms of the matchup, but it's pretty good across the entirety of the field. So what it sets up is this idea that the progression of Parkinson's is not just about worsening of motor dysfunction, but also about the spread of the underlying pathology and then the spread of symptoms through different regions of the brain which underlie different sets of symptomatology. Again, a whole body synucleinopathy as opposed to just a motor dysfunction. And so when we look at that, one of the potential mechanisms of action that we think about with prasinezumab is this idea that it can actually slow down or halt that cell-to-cell transmission of the misfolded alpha-synuclein and thereby start to modulate the disease progression and the disease course through that spreading process. And it's something, again, that we looked at very carefully in the preclinical setting before we chose this molecule to move forward to make sure that it had an optimal profile in being able to actually knock down that cell-to-cell transmission process.
Okay, that's great. Very helpful. So looking ahead to your phase 2 study, the Pasadena study, what would you say is kind of the hurdle for success there, and what would you and your partners at Roche want to see in order to kind of progress that into a pivotal trial?
Yeah, so I think it's worth maybe talking a little bit about the phase 2 design, which is, as you say, the Pasadena study. We think the study design is quite clever, and I think it's a very good study design. It's a two-part study. Each part is 52 weeks in duration. So there's a part A to the study and a part B to the study. Part A in the study enrolls patients with mild Parkinson's disease, and again, what we're asking patients to do in Part A of the study is to remain free of dopamine intervention therapy for as long as possible in that part of the study. And the goal there is really to track with several different clinical endpoints the progression of Parkinson's disease across that first year, and to assess whether the treatment with it's a 3-arm study, so we have 2 different dose levels of prasinezumab, so whether either or both of those dose levels provide a meaningful divergence of that disease course. And of course, the key fundamental piece here is what we expect in terms of our clinical hypothesis is we expect to change the course of the disease with this approach as opposed to having some acute symptomatic benefit, which would be differentiating from the other treatments currently available. So the idea then to have patients remain free of L-DOPA intervention for the first year should aid in our ability to look at certain endpoints. An example of that would be the UPDRS, or the Unified Parkinson's Disease Rating Scale, which measures in large part a number of motor dysfunction that you see in these patients as well as other behavioral disturbances. And obviously those would be impacted if patients were on L-DOPA, so we'd like to keep patients off L-DOPA while we assess that. So the primary outcome measure then for the study is at the end of the first 52 weeks, so the end of Part A, and the primary outcome measure would be the change in the MDS-UPDRS at 52 weeks in terms of change from baseline. We are looking at other endpoints that we think are important and informative as well. We'll be using some imaging-based approaches. DaT-SPECT measures dopamine transporters in the brain, and it's known to see some impact on that as the disease progresses. So of course we're interested in that as an endpoint. And our partners at Roche have done a really nice job as well developing digital biomarkers. So these are smartphone-based applications that patients can use that measure with high sensitivity things like tremor, gait, and other components of the disease. And of course we'll be looking at those as endpoints as well. And then patients will be able to move into Part B of the study. In Part B, patients are free to use L-DOPA or any dopamine intervention therapy. The placebo patients from Part A will be re-randomized into either the mid or high dose of prasinezumab, and then they'll be treated for an additional year. Here, we think with the introduction of dopamine intervention therapy, UPDRS will be of less value, but obviously things like the imaging-based approaches, DaT-SPECT, the biomarkers on the digital side in terms of smartphone-based technologies will continue to be very, very important, particularly for measures that would be less sensitive to intervention by L-DOPA, because not all components of Parkinson's are treated well with the current therapies despite their efficacy. So we're excited about this. I mean, in terms of what we're looking for, the study is a signal detection study. It's powered at 80% to see a 37.5% relative difference between either of the prasinezumab treatment arms and placebo, with a p-value which is one-sided at 0.1, so that approximates a two-sided p-value of 0.2. So this is about signal detection, and obviously what we're looking for is evidence that we can design the appropriate phase 3 study and move forward. And clearly we'll be working with Roche when we have those data and understanding and evaluating what the potential path forward is at that time. That study fully enrolled in December of 2018, and so we're looking for a primary completion date for the Part A of that study, which is 52 weeks in December of this year. Of course, additional analysis and evaluation will need to be done on the backside of that. How long that will take, we can't say with any specificity today, so the guidance we're giving right now is sometime in 2020. We expect to see the answer on that from Roche.
Okay, great. So you touched on the fact that prasinezumab is, it binds more to the aggregated form. Given the number of other alpha-synuclein antibodies in development from other companies like Biogen and others, how do you see prasinezumab as differentiated? Is that the factor, or How would you describe it?
Yeah, we haven't, we haven't seen a lot of data published on the preclinical side from some of the other alpha-synuclein antibodies out there, so I can't draw a direct comparison for you. I think what I can point you to is that we've published pretty extensively in this space, and not just with the murine or precursor form of prasinezumab, but with other antibodies that target other parts of alpha-synuclein as well. Not competitors' antibodies, our antibodies. And the reason we chose to bring prasinezumab forward was the consistency of the biology that we saw. I think we've published in 3 in vivo models. We've had, and a very consistent effect when you target the part of alpha-synuclein that prasinezumab targets. We see a very consistent biology. That biology has a positive impact on, again, in preclinical models, on reduction of pathology. We've shown that we can protect against the loss of cell neuron-to-neuron connection, the synaptic connection that you see in many of these animal models, and we've seen functional improvement come from that across multiple different behavioral endpoints. And so that consistency of biology and that preclinical efficacy that we've seen in those animal models has been it was a very important factor in us choosing to bring that molecule forward. There were other components we really liked about that molecule as well. I mentioned the idea of reducing cell-to-cell transmission, which we think is an important part of the mechanism. And also this idea, and you just mentioned it yourself, which is this high preference, if you will. It's an avidity factor. It's over 400-fold more specific to aggregated forms than it is to non-aggregated forms. And although there's not an entirety of consensus in the field around what the normal form and function of alpha-synuclein is, we do believe that it normally operates in probably a more monomeric form as opposed to the aggregated form. And our general philosophy as we think about targeting these types of proteins is to leave the normal protein function intact, even if you don't know exactly what it does, and to go after the more pathogenic forms that are more likely to contribute to disease.
No, I think the key thing, too, is to think about the sequencing of the 140 amino acid sequence, and where you hit that sequence matters in terms of epitope matters. And I think where we've published, it's kind of C-terminish, and I think there's other antibodies out there that have said they're more N-terminish. So I think we'll see what the data comes in this proof of concept trial for the phase 2, because we'll be the first ones to come up with that, and I think Biogen is about a year or plus that behind us. So we'll see from their data, how those differences show on efficacy.
Great. And then maybe switching to the 004 asset. So, with the 001 step back, what have you learned or what can you leverage from that in the development of the 004 asset going forward?
Yeah, that's a great question. So as much as possible is the answer. So clearly with NeoD1, we discontinued those clinical studies last year. Since that time, and I think we mentioned this on our fourth quarter earnings call, we've been busy looking at the data from that. It takes some time to kind of bring those studies in and make sure we have the data. And I think, the intent is to make sure we optimize learnings in 2 regards. First, for the field, because that was the largest study in AL amyloidosis that had been run, particularly from a double-blind placebo-controlled study on a prospective interventional basis. And so, we think that was a very important study, and we look forward to getting data to the field so that there can be learning there. But as you indicate as well, we're very interested in understanding how that applies back into our portfolio, whether it be PRX4 or other molecules. There are some key differences between NeoD1 and PRX4, both in terms of the disease that we're treating, as well as how the molecule interacts with the protein. NeoD1 recognized more of a conformational epitope around the light chain, which appeared to be common across kappa and lambda light chain components. PRX4 we actually approached a little bit differently. So PRX4, for those that aren't following the space, targets a protein called transthyretin. So it's a different peripheral amyloid disease caused by a different protein, which is the transthyretin protein. Transthyretin in its normal form, or TTR, exists in a tetrameric state. So it's actually 4 monomers put together in a tetramer, and that's actually important for its normal form and function. The way we targeted that protein was to work with a group that had solved the NMR structure and had identified kind of the key interface regions of those tetramers so that we could actually make antibodies that targeted those areas. And what that afforded us was the ability to interact with the protein when it was not in its normal tetrameric state. In other words, the areas that we targeted were buried. They were inaccessible in its normal form, but when that form falls apart, we can intervene in that process. And so it sees what we call mis-TTR species, i.e. the non-normal, non-native forms of TTR. And that was a very important differentiator, and I think we already know from the silencers and stabilizers that are in this space that this area of biology is quite important. And I think the prevailing presumption is that impacting the normal form of TTR is not what's providing benefit with those drugs, but rather the mis-TTR. And so specifically targeting those forms gives us a differentiated approach. We're calling the approach the depleter. So you've got the silencers, the stabilizers, and the depleters. And the depleters, obviously, the goal there is to go after mis-TTR specifically, both in its circulating form as well as in tissue, and remove what's in tissue. I think, we've got a phase 1 study ongoing. It's a 3+3 dose escalation study. We're looking at that. We've already, modified the design slightly, both based on what's happening in the field, but also based on our always growing understanding of both how to target proteins as well as how to best ask questions of that in the clinical space. And obviously, we'll continue to apply any lessons learned as we continue to move that program forward. The one thing I will mention that I think is very important, though, which is differentiated in our TTR program relative to others in the field, is most folks out there, when they talk about changes in transthyretin that they cause by intervening with their approach, they're talking in large part about that normal form of transthyretin, which represents the majority of what you can measure in blood. Because our PRX4 does not interact with that normal form, we actually had to devise an assay that specifically measured mis-TTR. And in fact, we're employing that in our phase 1 study. We have such an assay. It's very unique. We have shown that you can see log increases in mis-TTR in hereditary patients, hereditary carriers of the disease. And we think it's going to be a very important assay for us, both with respect to dose selection, but also really understanding how these drugs that are out there that work in this pathway influence this specific part of the pathway, which we think is probably more important in disease. So we'll be able to look at those different changes once those drugs are on the market, and we can actually get some research done in that space. So we're excited to deploy not only that molecule into the clinical space, but also the assay, which I think gives us a differentiated way of looking and thinking about that biology.
Gotcha, great. And I think you touched on this a little bit, but just maybe at a high level, when you look at the landscape itself for PRX004, where do you see it kind of falling and kind of how it's differentiated, with what's out there?
I mean, I think one thing to keep in mind is the data that we'll have coming out later this year. I think the mis-TTR assay that Gene just mentioned will help us understand that, because mechanistically, silencers, stabilizers, and depleters are potentially complementary to each other in a sense. And in the mis-TTR assay, when we get that data later this year, it'll help inform us about that mechanism, specifically ours, in terms of how far do we reduce that mis-TTR pool. And so then we also said on our fourth quarter call that we do want to get some patient samples, from a commercial setting perspective, to also understand how, let's say, tafamidis-treated patients or Onpattro-treated patients, how do they do on the mis-TTR pool? So then we can make an informed decision as to, does our mechanism fully reduce the mis-TTR pool, or is there a better combination between, silencers and stabilizers with depleters? But we'll be able to make that decision after seeing that data set. So I think those are key things that we're looking forward to at the end of this year and then into next year. That'll help answer the question you just asked in terms of what's our position in the space.
All right, well, we're just about out of time. Maybe one quick one on your earlier stage pipeline. What are you most excited about in your pipeline coming out next?
We're excited about all of our programs, of course. But I think one of the things that's quite interesting is we've got a couple of programs coming to cell line development this year. in particular tau and A-beta. We actually think that Alzheimer's disease remains a very important place to stay focused. It's clearly a devastating disorder. It's going to impact, I think, us at a societal level more and more. And I think we need to continue to keep focused in that space. We're very interested in the readout that will be coming out from some other folks in the field, particularly around aducanumab, Biogen's molecule, gantenerumab. So I think, these are going to be interesting studies that represent the culmination of, over a decade of evolving clinical science. And, we're going to start to understand how impacting A-beta plays in that space. And importantly, we're going to start to see how some of these tau molecules are reading out as well. We feel like we have a very differentiated approach in both places. We have a very rewarding collaboration with Celgene around tau. A-beta remains independent. And so, we'll start the cell line development process and start moving towards a potential IND in both of those programs, and that process starts this year.
Great. Well, I'm sure we could easily spend another half hour talking about A-beta, but we'll have to leave it there. So thank you, Gene and Tran. Appreciate you joining us today.
Thank you very much.